Hello, Kent Unit of the Northwest Kidney Center, the finest kidney center in the Western Hemisphere. This is Andy Brokenbrough, here to give you a monthly in-service. Today I thought it would be fun to diverge from our usual nephrology topics and instead provide some information on the recent monkeypox outbreak. Why is this important? Why learn about monkeypox? Well, because it is important that we recognize emerging infections. Any outbreak could be the next COVID-19 pandemic and could occur in any dialysis unit. And if you recall, among the first cases of COVID-19 in this country were some dialysis patients here at the Northwest Kidney Center. Monkeypox is an infection caused by a virus from the same family as smallpox, and this alone is justification for learning about it. It is typically an infection found in Central and Western Africa. First discovered in research monkeys more than a half century ago, and currently there is an outbreak spreading fast outside of Africa. The virus has been reported in, I think we're up to 42 countries now, including the United States, Canada, Israel, and throughout Europe. And as of 1 week ago, there were over 2,000 laboratory confirmed cases, including one death that had been reported to the World Health Organization. The current outbreak primarily has affected men who have sex with men and have reported recent sex with new or multiple partners. It's important to note that the rash seen with monkeypox is sometimes difficult to distinguish from that caused by smallpox, and there has been some concern that either monkeypox or smallpox could be used in the future for bioterrorism. Today we will review the virology and the epidemiology of monkeypox. We'll recognize the clinical presentation of monkeypox, and finally try to understand treatment and prevention strategies. Let's begin with the discussion of the virology and epidemiology of monkeypox. Monkeypox belongs to a viral family known as orthopox viruses. It was first isolated in 1958 from a colony of sick research monkeys. And the virus, as I mentioned earlier, is in the same genus as variola, which is a causative agent of smallpox, as well as vaccinia viruses. And these are the viruses used in the smallpox vaccine. And as I said, it's the close relationship to smallpox that makes this outbreak significant and should send chills down our spine. Let's take a moment to review smallpox. Most of you are probably not old enough to remember the horrors of smallpox, but smallpox has been one of the most devastating diseases known to humanity. It has caused millions of deaths before it was finally eradicated about 40 years ago. And it's believed to have existed for at least 3,000 years, based on the fact that it's been seen in Egyptian mummies. Its eradication represents a major achievement of modern medicine. It's eradicated in 1979 by the use of smallpox vaccine, and it was so effective that we stopped using smallpox vaccines in this country in 1972. Smallpox is the only virus to have ever been eradicated in humans, and it was possible because of 4 distinguishing features of the virus. There are no animal reservoirs for smallpox. The rash makes it basically easy to identify, so easy to identify the patients and isolate them. There's a short infectious period for the virus, so it's not like you have it and then you're infectious for 30 days before you get it. It's a short infectious period. And finally, there's a highly effective sterilizing vaccine. Smallpox usually presents with fever and vomiting, and this is followed by the formation of ulcers in the mouth and skin. And over a number of days, the skin rash turns into characteristic fluid-filled blisters with a dent in the center. Eventually, the bumps scab over and falling off, leaving disfiguring scars. The disease is spread either between people or on exposure to contaminated objects. The risk of mortality with smallpox is about 30%. It's higher among babies, and often those who survived had very extensive scarring of the skin, and some were left blind. Smallpox killed an estimated 300 million people in the 20th century and 500 million people in the last 100 years of its existence. We've never seen a pandemic like it. So with that as background, monkeypox is from the same family of virus as smallpox. And actually, it looks nearly identical under electron microscopes, so these sort of big brick-shaped virions. There are two distinct strains. The one from Central Africa is more virulent, and the one from Western Africa is less virulent and actually lacks a number of genes present in the other viral strain. It is believed that monkeypox virus has infected humans for thousands of years in sub-Saharan Africa. It is considered to be a zoonotic disease, so basically an infection that's derived from contact with animals. The first identified as a cause of disease in humans in the 1970s in the Democratic Republic of the Congo. Following its recognition as a human pathogen, 59 cases of human monkeypox were reported between 1970 and 1980 with a mortality rate of 17%. And all of these cases occurred in the rainforests of Western and Central Africa among individuals who had been exposed to small forest animals such as rodents and squirrels and monkeys. The virus is typically acquired through contact with an infected animal's bodily fluids or through a bite, although it can be transmitted by just touching an infected animal. In Africa, evidence of monkeypox virus infection has been found in many types of animals, including rope squirrels, tree squirrels, Gambian poached rats, also known as African giant rats, and different species of monkeys. Monkeys and humans are incidental hosts, so the main reservoir is unknown but is likely to be rodents. And this is an example of a rodent known to carry monkeypox. It is the African giant rat. Transmission can occur through close contact with infectious skin lesions or from contact with lesion material. Indirect transmission can occur through contact with materials or fomites that have become contaminated with infected materials, such as clothing or linens contaminated with infectious material from body fluids or sores. Transmission can also occur through large respiratory droplets. Now, the May 2022 outbreak that we will discuss in a little bit occurred through close contact with infectious skin lesions through sexual contact. So one of the take-home points from this in-service is my recommendation against having sexual intercourse with someone who has active monkeypox infection. As I mentioned a little bit ago, most outbreaks of monkeypox have occurred in Central and West Africa. Between 1996 and 1998, there was an outbreak in Central Africa of about 100 people. And we learned from this outbreak that the secondary attack rates were 80%. That is, if you had been exposed to someone with monkeypox, you had an 80% chance of contracting the virus. And in this outbreak, the mortality was 5%. Between 2005 and 2007, there were 760 laboratory-confirmed human monkeypox cases identified in the Democratic Republic of Congo. And this represented a 20-fold increase compared with the 1980s. Interestingly, cases were 5 times higher among those who had not received the smallpox vaccine. So we learned from this outbreak that the smallpox vaccine offers some protection against monkeypox. In 2017, there were 80 cases in Nigeria after almost a 40-year period with no reported cases. And the cases were thought to have resulted due to travel to Nigeria. And in 2022, the World Health Organization reported that monkeypox was endemic in several African countries, including Benin, Cameroon, the Central African Republic, the Democratic Republic of Congo, Gabon, Ghana, Ivory Coast, Liberia, Nigeria, the Republic of Congo, Sierra Leone, and South Sudan. Now, from January to May of 2022, there have been 1,200 cases in the Democratic Republic of Congo, so a clear increase in number of cases and 57 deaths. So all of this was fine and interesting from an academic and an infectious disease standpoint until monkeypox came to U.S. soil in 2003. So the first cases in the Western Hemisphere occurred at this time in an outbreak in the United States. There were 71 cases of human monkeypox in 6 states. The outbreak occurred among people who had just purchased pet prairie dogs that had acquired the virus from African rodents when the 2 species were housed at a distribution center in Illinois. And during this outbreak, monkeypox appeared to have a very low person-to-person transmission, unlike smallpox and unlike certain outbreaks that we had talked about earlier in Africa. And in one study of 57 healthcare workers that were exposed to patients with monkeypox, none reported signs and symptoms with the disease. That said, many of them probably had been vaccinated against smallpox, and also this was a monkeypox variant from Western Africa, which is less virulent and lethal than the variant from Central Africa. As an aside, since that time it's been illegal in this country to own a prairie dog or animals from Africa. In July of 2021, a patient was diagnosed with monkeypox in Dallas, Texas, after traveling to Nigeria. And finally, in May and June of this year, there's been this international outbreak of monkeypox, which I alluded to. There have been 84 cases thus far in the United States, including in Washington State, related to an initial European outbreak. So what was this European outbreak? Well, in May of 2022, there were multiple clusters of monkeypox reported in Europe, including Portugal, Spain, and the United Kingdom. Most cases were identified in men who have had sex with other men and who attended one of 2 rave parties in Spain and Belgium. Now, just to put it in context, prior to the outbreak, in May of 2022, there had been only 7 cases of monkeypox reported in the UK over the past 4 years, all of which were associated with travel to endemic countries. And currently in the UK, there are 793 cases. So a huge increase in number of cases of monkeypox, all as a consequence of these 2 raves. All right, now let's switch gears and discuss the clinical presentation of monkeypox infection. So the classic incubation period of monkeypox virus infection is usually from 6 to 13 days, but can range from 5 to 21 days. And we know this from the 2003 United States outbreak. Approximately half of the patients in this outbreak reported a scratch, bite, or petting an infected animal. And persons with a history of an animal bite or a scratch probably had a shorter incubation period than those with just petting or tactile exposure, so 9 versus 13 days. The majority of monkeypox infections are mild or asymptomatic. Less severe than smallpox, monkeypox typically causes flu-like symptoms such as fever, fatigue, muscle aches, swollen lymph nodes as shown in this photo here, as well as a characteristic rash. So the rash in monkeypox, like smallpox, is dramatic. Typically starts out on the trunk and then it spreads peripherally to involve the palms and soles of the feet. Lesions can also involve the mucous membranes, for example, the mouth, even the eyes, and usually are a half centimeter to 1 centimeter in diameter. The lesions often begin as flat little spots called macules or little bumps called papules, and then over a 2 to 4 week period, they progress to the characteristic blisters and pustules that we see, and then they finally umbilicate, and then they fall off, and then they scab over, and you get scars. Now, interestingly, they can appear anywhere: the face, genitals, palms, soles of the feet, basically anywhere in the body. In the cluster of cases reported over the last 2 months, so that many of the patients have presented with lesions just in their private areas, so either around their anus or in their genital or the perianal area alone. Again, strongly suggesting that these lesions were spread through sexual contact. So the clinical features are helpful in making the diagnosis of monkeypox. However, laboratory confirmation is necessary to distinguish it from, other pox viruses. So varicella or chickenpox, smallpox, etc. You can make the diagnosis with either a PCR or an ELISA, which is an antibody test. And if the diagnosis is being considered, it's required by law that you contact local and state public health officials, and the CDC should be notified so that samples can be processed quickly. Several infections need to be considered in the differential diagnosis of monkeypox. These include varicella, which is chickenpox, human or herpes simplex virus, smallpox, which is eradicated from the wild but could still be used for bioterrorism, and other pox viruses. Now, given the worldwide eradication of smallpox, the most likely diagnostic consideration is varicella or chickenpox. Now, unlike varicella, where vesicular lesions are characteristically in different stages of development and healing when the patient is examined, monkeypox lesions are all generally at the same stage. Mortality associated with monkeypox depends primarily on geography. In Central Africa, the fatality rate is approximately 10%, and the deaths generally occur in the second week of illness. In contrast, in the outbreak in 2003 in the United States, there were no deaths. And there were probably several factors that explain the difference. One may be a healthier U.S. population, greater availability of supportive medical care, a less virulent strain of monkeypox. Again, it was the Western variant and not the Central variant. Finally, a lot of the healthcare providers who were caring for the patients who had monkeypox infected at the time likely had been vaccinated against smallpox. So how do we take care of patients who have been diagnosed with monkeypox infection? In general, supportive care is a rule. Most patients have mild disease and recover without medical intervention. Again, they can recover with scars, which is pretty bad, but they survive. Others who have risk factors for dehydration, nausea, vomiting, difficulty swallowing, might require hospitalization for intravenous fluids. For the seriously ill patient, supportive care is necessary until the patient recovers from infection. Okay, so antiviral treatment may be reasonable for patients with severe disease and those at risk for severe disease, such as immunocompromised patients, those less than 8 years of age, pregnant or breastfeeding women, and patients who have complications related to the infection. Treatment can also be considered for monkeypox infection in traditionally atypical sites: the mouth, the eyes, the genital area. In general, tecovirimat is the treatment of choice, although some experts have suggested that dual therapy with tecovirimat and cidofovir in patients with severe disease may be more effective. Regardless, the regimen selection should be made in consultation with public health officials. Of course, the best management of monkeypox involves prevention. Prior smallpox vaccination with vaccinia virus has a significant protective effect against acquisition of the monkeypox virus and appears to ameliorate the severity of the infection. In an African study in 2005, vaccinated people had a five-fold lower risk of acquiring monkeypox for a vaccine efficacy rate of 81%. It turns out that prior vaccination in most cases was remote. I mean, had occurred decades prior, and yet was still protective against West African monkeypox. So we know from these studies that vaccination, the benefit of vaccination can be maintained for years after with respect to prevention of monkeypox. In addition to monitoring and isolating close contacts, post-exposure vaccination can be considered for certain patients after exposure to monkeypox. Say, direct contact with a patient or material from a patient's room without wearing personal protection equipment. The optimal time for monkeypox post-exposure vaccination is within 4 days, although vaccination can be considered for up to 14 days of a close contact exposure. Close contact is defined as direct exposure within 6 feet of a probable or confirmed monkeypox case in an animal with respiratory symptoms such as nasal discharge or cough or conjunctivitis, or in a setting in which the animal has been manipulated, like on an exam room table. Vaccinia immunoglobulin is available if the vaccine is contraindicated, so it's a live virus, so immunosuppressed patients could receive the immunoglobulin rather than the vaccine. Of course, infection control precautions are very important. We know all about this from COVID-19, the standard precautions including contact, droplet, and airborne safety measures. Now, when the rash is present, persons with suspected monkeypox should be considered infectious and isolated until all of the scabs separate and the results of a throat swab PCR are negative. So in summary, monkeypox is an orthopox virus which was first isolated in 1958 from a colony of sick research monkeys. Significantly, it's the same genus as smallpox and vaccinia viruses. Typically acquired through contact with an infected animal's bodily fluids or through a bite. Monkeys and humans are incidental hosts, and the likely reservoir is rodents. Human-to-human transmission can occur. Transmission typically occurs through close contact with infectious skin lesions, as demonstrated by the recent international outbreak associated with sexual promiscuity. Most cases occur in Africa or travelers coming from Africa. The typical incubation period is 1 to 2 weeks. Predominant symptoms may include fever, rash, swollen lymph nodes, muscle aches, chills. And most patients with monkeypox have a mild illness, although sometimes people have oral involvement and had to receive some intravenous fluids. Diagnosis is based on the clinical features plus laboratory confirmation either with an ELISA or a PCR. And if you suspect the diagnosis, it's very important to notify local and state public health officials and the CDC. Most patients have mild disease and don't require any medical intervention. Standard contact precautions are important for managing a patient who's hospitalized with monkeypox. And finally, the use of a smallpox vaccination for pre-exposure or post-exposure prophylaxis is reasonable. Time for the monthly quiz. Da, 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 da. True or false? Monkeys are the natural reservoir for monkeypox. And the answer, of course, is false. It's probably rodents. Rodents are the natural reservoir. Because of that, there's actually been some talk about renaming monkeypox to something else. Question number 2, true or false? Monkeypox can cause significant scarring of the skin. The answer is true. So even though the mortality rates of monkeypox may be low, at least in the United States, it can cause significant scarring of the skin, which is can be pretty debilitating. Question number 3, what was the cause of the May 2022 international monkeypox outbreak? That's right, sexual promiscuity. So speaking strictly from an infectious disease standpoint, sexual promiscuity is very, very bad from the standpoint of spreading infectious disease. Next question, what are the main clinical manifestations of the monkeypox infection? So, fever, rash, swollen lymph nodes, muscle aches, and chills. The predominant clinical manifestation, of course, is rash. And the final question, is vaccination protective against monkeypox? And the answer is yes. So it's very effective. Of course, we don't distribute the smallpox vaccine anymore, but if we had more cases of monkeypox, that is one option. This concludes the June 2022 in-service for the Kent Northwest Kidney Center. Thank you for being the best dialysis unit in the entire world. I really appreciate everything you guys do. This is Andy Brokenbrough signing out until next month.